Gaurang bhai, good morning.
Good morning, sir.
Good morning, everybody.
Good morning, sir. Okay. So today
Sanjeev,
we
are you
have
there?
Sir.
Sanjeev is there, who is presenting a case.
Yes, Sanjeev. Sanjeev.
Yes, good morning, sir.
Good morning.
Sanjeev, have you prepared that sometimes we are going to discuss a short case? So have you prepared as a short case also?
Yes, sir.
So because examiner, one of them may ask you straightly, what are the positive findings? I did not see them in your slide. That's why I was asking. Anyway, we'll just. Good morning, Dattaroy sir.
Good
Seeing you
morning,
after a
boss.
long time.
સાહેબ આ રાખવાનું કારણ એ હતું કે પ્રિલિમ્સમાં તમને ખ્યાલ આવ્યો કે આ લોકો they are still a little confused regarding short cases.
Short case, there is a lot of difference than long case. Because
Yes,
if we
sir.
are going to present it, okay, we will discuss it accordingly. But remember, we are going with a short case. Keep that thing in mind. Gaurang, good morning.
Good morning, sir.
Good morning.
Good morning, sir. Good morning, sir.
Kirit.
Yes, sir.
Good morning, Kirit bhai. So,
Sir,
sir,
good
basically, the plan is કે short case ની જેમ જ આપણે ભલે discussion લાંબુ ચાલે એનો વાંધો નથી, but the history or the case should be a short case only.
Exactly.
So we have two short cases, one on stoma and one on amputation stump. And this, please consider it as short case only. The discussion may go long, but the history and the presentation part should be as per the short case. I think we are joined by almost everybody. Dr. Dattaroy sir has already joined. Dr. Gaurang Rayani, he is an associate professor at Gotri Medical College. Kirit bhai is professor at NHL Medical College. We should be joined by Dr. Sanjay Bhatt. He is.
I think Apurva, he has joined. I can see him.
Namaskar,
Sanjay,
sir.
Good morning, sir.
Good morning, sir.
Namaskar, sir.
He is professor at RML Lucknow. And so, sir, today we are going to present a case on a short case on stoma and amputation stump. The presentation will be in the same way as a short case. The discussion may differ. Sir, chalu kariye?
Oh, yes, sure.
Yeah, go ahead.
Right. Thank you, sir. Sanjeev, start.
Yes, sir. Good morning, sir. I'm Dr. Sanjeev Kumar presenting a case on stoma. 18-year female patient residing at Ahmedabad operated for emergency exploratory laparotomy with loop ileostomy 7 days back. Patient had history of generalized abdominal pain with fever with night sweat for 30 days and diagnosed as abdominal tuberculosis 15 days back and took anti-tubercular therapy for 1 week and then she discontinued. Following which patient presented with obstipation, abdominal distension and bilious vomiting for 3 days. Stoma become functional on second post-operative day. At present, patient emptying stoma bag approximately 4 to 5 times a day with average stoma output of 800 to 1000 ml per day, yellowish in color with semi-solid in consistency. A drain placed on the left side of the abdomen with daily output of approximately 50 to 60 ml serous discharge. Patient is using transparent, disposable and one-piece stick-on type stoma bag without belt.
Before we go to the next slide, just go back to the first slide. You mentioned patient was operated for emergency exploratory laparotomy with loop ileostomy. Did
Yes,
the patient tell you it was a loop ileostomy?
Sir, the patient just discharged yesterday only, sir. We only
The
operated.
history has to be in the patient's language.
Yes, sir. The patient.
What did the patient actually tell you?
Yes, sir. Told that there was a bowel perforation and which the one single bowel perforation was there in the history, sir.
No, no, something was done, right? Patient
Yes.
must have told you that something was done. Patient said operative procedure was done and something was done or kept or brought in the on the abdominal wall.
Yes, sir.
So if you mention a loop ileostomy, you are getting biased, right? That's the first thing. And second thing is, it has to be in the patient's language. History has to be in the patient's language. Examination is fine, but examination also is you have to describe it and then come to the conclusion whether what type of stoma it is.
Yes, sir.
Okay, go ahead.
No complaints of itching in peristomal region, no complaints of fever at present, no complaints of blackening of stoma, and there is no significant past history, family history or personal history. Examination.
Sir, same thing what sir had said, because money in your history, there are medical terms that need to be in layman's language. There are a lot of things,
Yes, sir.
and you should correct them.
Yes.
In fact, nowadays only history is with you. Rest of the things, investigations have taken it so far that you can't just tell anything. Just history will help you, nothing more. That is only thing I wanted to continue.
On inspection, I have examined the patient after informed consent in proper light and adequate exposure in the presence of female attendant.
Do you have a
human-
picture of the stoma?
Yes, sir. Here, the two lumen visualized, one is slit like upper one. Two lumen visualized of approximately 2.5 into 2.5 centimeter and 2.5 into 1 centimeter in right iliac fossa, approximately 5 centimeter lateral and 4 centimeter below the umbilicus. Mucosa is pink without edema with yellowish semi-solid output from the lower lumen with stitch in situ. Surrounding skin is normal. Healthy midline laparotomy incision extending to lower abdomen approximately 15 centimeter long with suture in situ is noted. And a corrugated drain noted in the left iliac fossa with stoma bag in situ with serous discharge.
You continue your this thing.
Yes, sir. Inspect on palpation, inspective findings are confirmed, and two lumen of size approximately 2.5 into 1.5 centimeter superiorly and 2 into 1.
I'm just interrupting you. Could you go back to the next previous slide?
Yes.
Anything missing from your inspectory findings?
Sir, mucosa stoma is flush to the skin level, sir.
That is okay. Anything else?
And there is no glass rod or IFT kept, sir.
Would you like to tell us if you have told the patient to cough?
Yes, sir.
And what is the significance?
Sir, in later part, there is a complication that might be peristomal hernia, which can be seen, sir. If on coughing, we can see the cough pimples, sir.
Can it occur in the immediate post-op period?
It is less likely, sir. It is usually late complication.
Supposing the patient has post-operative distension of abdomen.
Yes, sir. In immediate post-operatively, it is less likely, sir.
Okay, go ahead.
On palpation, inspectory findings are confirmed. Two lumen of size approximately 2.5 into 1.5 centimeter superiorly and 2 into 1.5 centimeter inferiorly noted in the stoma with mucosal bridge without any suture in the right iliac fossa. Sir. Peristomal examination is normal. Surrounding skin temperature is normal without tenderness.
You said without any suture in the right iliac fossa. So what do you want to say then?
Sir, I want to differentiate it between the loop ileostomy and double barrel ileostomy. The mucosal bridge will have a suture in double barrel ileostomy, sir, and that will be absent in loop ileostomy, sir.
Okay, and one more thing. Are there any skin stitches at
Yes,
present?
sir. Yes, sir. Skin stitch present, sir.
Skin stitch with the stoma, right?
Yes, sir.
Okay.
On systemic examination, per abdomen is soft, non-tender, no palpable organomegaly, normal peristalsis present, sir. And per rectal examination is normal, no inguinal, axillary or cervical lymphadenopathy. RS, respiratory system, cardiovascular system and CNS examination is unremarkable.
One thing is your findings, I mean, the same approximate in inspection as well as in palpation. I mean, in palpation, you measure. You see, if you had said approximately 1 inch, I would have not had any issue. But you have said 2.5, 1.5. That means what you measured in palpation, you put in inspection. Fact
Yes.
remains that the approximateness, just what you look at, how you by look, you can't replicate the findings of palpations in inspection. You see, you need to have a differentiation because you are just looking at it. Measurements like 0.25, 0.5, I mean, this says that you have already taken it and now you are presenting it.
Yes, sir.
And I mean, that thing you approximate sizes.
Yes, sir.
Yes. Okay, fine. Proceed.
My diagnosis is uncomplicated temporary loop ileostomy done for ileal perforation, likely due to tubercular etiology.
How did you know that it was done for ileal perforation, and how did you come to the conclusion that it is because of tubercular etiology?
Yes, sir. Sir, on inspection, we can say that the stoma is in the right iliac fossa, which is more likely due to ileal stoma, sir. And we can see that patient is also giving history of AKT taken during the previous history of AKT, anti-tubercular therapy is there, sir. And also sir, during the OT, sir, mental caking were present, sir.
That was not mentioned. I mean, point is you said fever. Why it can't be typhoid perforation? You said fever there, and though you did mention that night sweats, but you never described fever as such. You see, just a fever, if you had just said low-grade fever, one would have taken an idea that it would be tubercular. Missing out third week perforation in typhoid can be, I mean, one month history, third week perforation missed out can be there,
Yes, sir.
right?
Yes.
And one more thing, I mean, double barrel, you hardly see sutures in the mucosa. You hardly see them. It is almost similar. It is almost similar once it has been done by somebody and you are visualizing it now. right?
Yes, sir.
What is, what is the difference between double barrel and loop?
Sir, in double barrel, usually
Not
we
making functional, not in making, not in making, in functional. Why will you make a double barrel and why a loop?
Sir, whenever resection of bowel is needed, at that time we need to go for a double barrel ileostomy, sir. And if only we are taking out the perforation or for decompression, then we can do loop ileostomy, sir.
Mainly once, if you want a complete diversion, nothing should go downstairs. You have done an anastomosis downstairs, so you want a complete diversion. You need a complete, so that in loop, a breach is always present and some amount of the fluid, the content may go down in the down stream. If you want complete diversion, then
Yes,
right?
sir.
Even without this thing, resection at that point of time, right?
Yes, sir.
But if you resect the bowel, you can also do anastomosis. You can also do proximal diverting ileostomy, loop ileostomy. It's not always you have to perform double barrel when you go for resection, because you can do resection anastomosis and you can bring out the proximal loop as a loop ileostomy also.
Yes, sir. And distal loop as a mucus fistula, that we can do in divine procedure, sir.
And now we can do loop ileostomy in such a way that proximal loop it's elevated than distal one, so most of the fecal matter go into the stomach bag rather than going into the distal loop.
Yes, sir.
You say this is a loop ileostomy. So what are the points favoring your diagnosis, and why not end ileostomy?
Sir, it is ileostomy because location is in the right iliac fossa, and the two lumens are visualized, and we can palpate the two lumen. So it is more likely loop ileostomy, not end ileostomy, sir.
Anything else? Anything else? On seeing the stoma, you can say that this is a ileostomy and this is not a colostomy.
Sir, in mucosa, we can see the color of the mucosa is pink, sir, which is in ileostomy, sir, and colon mucosa will be pale, sir, and the characteristics of mucosal ridge is of ileostomy, sir. Mucosal ridge is seen, which is of, and the lumen is also narrow, small, sir, compared to colostomy, sir.
Is there any technical difference between formation of ileostomy and a colostomy?
Yes, sir. In ileostomy, usually we port the mucosa, sir, by tripartite suture, sir. And in colostomy, usually we do flush level at the level of skin only, sir. We do not port the mucosa, sir.
Why you don't pout in colostomy?
Uh, Sir, bile in the
It's
ileostomy,
all
sir.
about content, right? It is the
Con-
content that is going to come.
yes,
That
sir.
is fine.
Content causes more irritation to the skin, which is the liquid content containing the bile, which is more irritating to the skin. So in potting, sir, it will go directly to the stoma bag, and it will be less irritating to the surrounding skin, sir.
What is ideal ileostomy?
Sir, ideal ileostomy is it should be in the away from the midline suture line. It should be away from the any bony prominence. It should be away from the umbilicus or any scar site. It should be visible to the patient, and mm, aw- mucosa should be healthy, and ileostomy, though, it should be the potting in nature, and yes, sir.
whether
You
you
didn't-
Which of the opening should be higher up?
Yes, sir.
Is
In
there
and
any?
yes, sir. In the distal proximal lumen should be inferiorly and or laterally, sir. And distal should be superiorly or medially, sir.
My point was which should pout more,
Proximal one, sir.
proximal or distal?
Proximal, sir.
I think it should be distal one, so that nothing goes into the distal lumen. You check it out, what I
Yes,
feel.
yes, sir.
So you said that the patient was already on AKT.
Yes, sir. Patient taken only for 1 week, sir, and then she discontinued as she was symptoms get aggravated, sir, and she was very uncomfortable with AKT, sir. And after 1 week, she came to our hospital, sir, with acute
Sanjeev, we are discussing this as a long case. Suppose, what is the actual time you get to write down history when in exam you get a short case? How much time do you get for an examination before examiner comes to you? What is the time limit?
sir.
Do you understand my question or not?
Yes, sir.
How much time do you get?
In short case, sir, 15 minutes, sir.
10 minutes at the most. Do you understand?
Yes.
So how will you do all this measurement in 10 minutes? I would really like to know. Nothing against the history, just I am, for the perspective of a short case, I am asking you. So you should always be ready with the plan B in a case of short case. Most of the time, examiner will come and ask you a very simple question. So what is the first question? Take my word for it. What is your diagnosis? What is your diagnosis?
Sir, my diagnosis is uncomplicated temporary loop ileostomy, sir.
Which one? Temporary loop ileostomy. Very
Yes.
good. So then your discussion will start. So keep this in mind. The next question is, what are the positive findings which suggest that this is loop ileostomy? Tell me those points. Positive points, no negative points.
Yes, sir. The stoma is in right iliac fossa.
So you start straight away with stoma. Examination, positive finding include positive finding in history, in inspection and in palpation, which will give you the diagnosis. Actually, we cannot call it as a diagnosis, it's a PIP, but anyway, it doesn't matter. So diagnosis is slightly misnomer, but doesn't matter.
Yes, sir.
So what are the positive finding in history?
Sir, in history, she gave the history of abdominal distension, following which she underwent.
My friend, you are not discussing case of laparotomy. You are discussing a case of ileostomy. As sir had said, unfortunately, patient was with you, so you know all history. In exam, you cannot say patient. Patient was operated for exploratory laparotomy for intra-abdominal condition and had a stoma.
Yes.
And then you start, there is no any on inspection this, on palpation this. This is how you establish your diagnosis. You cannot say patient presented with abdominal, that is not ileostomy, that is for a abdominal complaint. So we are discussing ileostomy, not a laparotomy. So at the most, what you can say, patient had been operated for laparotomy. You should not start patient had a distension of abdomen. That is not a part. Yes, sometimes you are lucky that patient had come before 7 days only and you can say that. But in a normal circumstances, suppose patient operated outside and comes to you after 3 months. What will you say?
Patient underwent laparotomy.
Yes, exploratory laparotomy most of the time, because it is very difficult to establish what may be the cause. Yes, sometimes it is suggestive of it, but this is history. It is not in a ward exam. Do you understand? So you should say patient was operated for exploratomy and stoma was created, right?
Yes.
So why on positive finding that this is ileostomy? Tell me that, those.
Sir. Patient after laparotomy, patient is giving history that
I am asking you finding in inspection,
inspection,
which suggests this is ileostomy. Kirit has already asked you this same question.
yes, the site of stoma is in the right iliac fossa region.
Right. So stay site in right iliac fossa. Don't say 2 centimeters away from that. Let the examiner ask you. You should say site is of ileostomy. Very good.
Yes.
Then
Uh, then the content is liquid with semi-solid consistency, sir.
very good. Don't say bile. You said one word bile. It can be bile. When it can be a bile in ileostomy?
Uh, Sir, usually in the early part of
Why? Why in early part?
sir, in early part because the intestine is not adapted, so the slowly first bile
What
will,
adaptation is required?
sir, the mucosa will
It depends upon the site of ileostomy. If ileostomy is little proximal, the last 30 centimeter for reabsorption bile is gone. So in early stage, there may be a bile. It depends upon the site of ileostomy. And in early ileostomy, even when it is terminal, absorption capacity is not there. So you should say liquid content. Better word is right. Then what?
yes,
Why it is ileostomy?
mucosa is pink in color.
Yes. Very good. Show me the picture meanwhile. Okay, fine. So on inspection, can you say it is a double barrel? Sorry, loop ileostomy. Your diagnosis is loop ileostomy. On this inspection, can you say it is a loop ileostomy?
Sir, in this only the slit like
I am asking you very simple question. Understand the question. Don't jump one answer. What did I ask?
in inspection, can we say it is a loop
So
ileus?
answer is yes or no.
Can you zoom in?
No, that's what I'm asking you. Looking at this, can you say it is a loop ileostomy or end ileostomy?
It looks like end
Looks
ileostomy.
like new. Can you say from this
End ileostomies.
it is end ileo? No, it is loop. Why?
Because sir, on examination we can clearly see the two lumens. We can clearly
Palpation or on inspection?
on palpation two.
I'm asking you on inspection.
On inspection, sir, on only the clear slit like
Yes. So that should be
superiorly we
your
can.
finding in exam. Do not decide that it is a loop ileus. What I can see on this is a single opening in a stone. It cannot decide whether it is a loop or end. So what will be the finding if it is end ileostome?
Uh, in end ileostomy, there will be only one lumen
Here
will be,
also only one.
and it will be uh, protruding out
Very good. There will
from
be
the scrotum.
formation of nipple, at least 2.5 centimeter protruding with everted mucosa, which will not be there. But you should say, sir, on inspection and from history point of view, it looks like a loop, but I will confirm in palpation. So these are the difficult questions, those will be asked. The answer may be variable. You may be right, but you should be able to prove it. Okay, on palpation,
On palpation, sir, two lumen, we palpated the two lumen. One lumen is going proximally and another is distally, sir.
obviously it will be there. But which lumen is going proximally and which lumen is going distally?
Sir, proximal lumen was going downwards
And medially,
inferiorly, sir.
downwards and medially.
And medially,
Ah,
sir, and distal lumen was superiorly, sir, and inferiorly.
superior, supralaterally. What is significance of that?
Uh, uh, Sir,
It give you
it is
the
a
rough.
relation is different than twisting is
One
possible.
is a twisting or it is something else. So that is an important direction, not only tuning, direction is also important. What else can you palpate?
Sir, we can palpate the whether any we are able to pass through the sheath or not, or
Constricting ring or there.
constricting ring.
Staining of the finger on which side? Do you understand? It can be on both sides. So say both sides, and we have a discussion on that. Don't I say that only from proximal. Why can there can be a staining from distal loop also?
Yes, sir. Staining can be there in both proximal and distal.
Why in distal?
Sir, the content can go
Overflow. That is the
overflow.
disadvantage of that.
Yes.
Okay. So what is the point against that it is a loop ileostomy? Sorry, I am taking over, but I had a few questions I'm going to ask.
One is on inspection, it is not clearly visible to lumen, sir.
So what other things you could have done to divide that? Yes, it is proximal and distal, which is commonly done. Passing
Sir,
a rod
passing
through
a
mesentery.
glass rod or IFT in the mesentery, sir.
Mesentery. So that will conclusively tell you that this patient is having a loop ileostomy, which is not there in this case, though it is very early. It suggests that it can be an ileostomy. You don't know on inspection. Please, sir. So point is that you should be ready with positive finding only. Have you done PR?
Yes, sir.
So what are the finding in PR?
PRs are collapse with normal, not fixed mucosa, sir, with
What do you say first thing?
um,
Collapse.
collapse, sir.
What is that? I did not get it. What?
Collapse, sir, not ballooning, sir.
Normal.
Normal, sir. Yes.
What is collapse?
Collapse, we can able to touch
Anterior and
the.
posterior rectal wall fused.
No, sir.
So why do you say collapse? Another point, do not deviate from a normal region. Why simply you cannot say it is normal? Why you need to say it is collapse? If it is ballooning, you can say ballooning, but why you need to say collapse? Normal. So
Normal.
PR is normal. So what else did you see in PR?
Stool.
One more point, sorry. But in exam, most of the time, examiner do not expect you to do PR. Understand this point. So clarify with the expert whether you are supposed to do PR. And if you have not done PR, say in exam that, sir, PR is not done. This is just to complete the short case history. Keep this in mind. Do not, because you are tempted that I have done, sir, PR yesterday in this patient, so I know the finding. You are not supposed to say that. Do you understand? So in exam, be ready. Most of the time, PR is not allowed because the same patient come for multiple students. So be ready and do not fabricate any finding. But anyway, let us. You have done PR. So what are the other things did you see?
Sir, the stool or consistency of the
Fine. You are
content.
saying that is all right. What else? In context of patient is having ileostomy.
Sir, whether the tone of the anal canal is normal or not.
Why you need to know the tone?
Sir, uh, because if later if you plan for the ileostomy closure, sir, so if
It has
PR,
nothing to. The anal tone will not decide that thing. What else do you see? Very obvious things which you,
sir,
as a clinician, you are supposed to see.
any mass or growth is there.
Correct. Why there should? Very good. One point. Because laparotomy might have been on something inoperable growth.
Yes.
You understand? So that is the one point. You should always keep this thing in mind. What else?
Any bleeding or
No, bleeding. There can be a collection in anterior.
pouch,
You understand?
Collapse.
Pouch.
pouch
Because
of
which
the
is post-operatively pelvic abscess or pelvic collection is important. So keep that thing in mind. Apurva, please take over. Sorry. Yes, sir. Kirit bhai, anything you would like to ask?
Even in rectal examination, you should look for whether any form stool is there or not.
I think
Because
Nina ma'am is also there. Ma'am, आपने भी कहीं किया हुआ है तो.
Yes. What are the indications for doing loop ileostomy, Sanjay?
Ma'am, loop ileostomy we can do for diversion, ma'am. Like if we have done ileorectal anastomosis distally or IPA or any distally significant diverticulitis is there, or there is because of trauma to the perineal region, trauma to the rectum or anal canal, or in multiple fistula, we can divert the fecal by doing the loop ileostomy, ma'am.
What
So,
are the
so in,
commonest indication? This is the wrong thing.
Ileal,
Commonest indication what you operate
yes,
routinely?
ileal perforation, single ileal perforation is the most common we are
So
doing.
all patient having
all
ileal
ileal
perforation, you will go for a stomy.
No, sir. Not in all cases. If there is a single small perforation, and it is a sign of peritonitis is very less, we can do the primary closure or a resection anastomosis.
Why resection anastomosis?
Why do you say about resection? Multiple
This is
perforation. We are not talking about multiple perforations.
so Sanjeev, this is the problem with students. They say we do not give more information than needed. Your whole topic will divert it. What are the indication of resection and anastomosis in perforation?
Sir, if it is associated with
So what is the dictum is if you need a resection, better to divert. Do you understand?
yes.
So that is the one dictum, not necessary. But it is not on perforation. Suppose patient come with traumatic multiple perforation and patient come with enteric multiple perforation. Will you do the same treatment?
No, sir.
What is difference?
In traumatic, we will do resection anastomosis, and in the multiple ileal
Why not
perforation,
suturing? Why you are hell bent on resection anastomosis?
we can suture primary
We can
repairs
nahi.
around.
Primarily, if it is a traumatic, closing the perforation is the treatment. Resection, when there are multiple very near
it
to
still
each other.
depends on it
Yes.
still depends on the patient conditions and the sepsis, matlab, intraperitoneal collections and patient conditions. Sometimes patient presented too late to you and there is so much contamination inside. You can go for stoma also. It depends on the patient condition. You cannot be biased before going for a surgery. It is something like you go inside, see the condition, and then you decide whether to go for a ileostomy, whether to go for a resection anastomosis, or whether you go for a primary repair. And you tell in a patients having a trauma to the perineal region, rectum, why you go for a loop ileostomy? Why not colostomy?
Yes, that's the question I was going to ask, but he has left, I think. Sanjeev?
Yes, sir. Colostomy, doing colostomy is better than ileostomy, sir. But if the trauma,
But why?
Arre,
Why?
arre, arre, arre.
Why?
because
Why?
because the content is solid in consistency in the more of solid and consistency in colon, sir.
So you
So it,
better say managing colostomy is better than managing ileostomy,
yes, sir.
because creating a colostomy it's a difficult than creating a ileostomy, but managing colostomy it's easier.
Yes.
Yes, any other reason?
The
Why you go for
complication.
a ileostomy? Still people do ileostomy. Why? Because remember, this is a controversial. Many people still believe you should do colostomy if it is a left side colon disease. Some say you should go for ileostomy. So what is the advantage of ileostomy over colostomy? No advantage? Then why we have done it?
Sir, easier to do, and also the if the trauma causing more
Trauma is
pain.
not the whole thing in surgery. What are the advantage of ileostomy? There are many. You have said one easy to do it. Agreed. Because there is a long mesentery and you can do it easily. Bring out it easily, which is difficult in colon, particularly transverse colon. It has a momentum. Sometimes momentum comes in way. It has a shorter mesentery. Arcade is different than ileum. Ileum has a multiple arcade. So chances of ischemia is quite less. Right? Same thing goes for a closure. Closure is easier when you have done a ileostomy, right? Sometimes some lesions in colon requires extensive mobilization. If you have created a colostomy, sometimes it becomes difficult to do a mobilization in a second stage. And if you have done a ileostomy, there is a leeway for the reconstruction. So there are reasons for doing. Disadvantage of ileostomy?
Sir, electrolyte imbalance.
Okay.
Which electrolytes are reduced?
Sodium and potassium. More sodium loss.
Okay.
Periostomal skin excoriation is more in ileostomy. And
What else?
prolapse, possibility of prolapse is more in ileostomy.
Okay.
So now tell me in which conditions you go for a and ileostomy.
And ileostomy, I will go in if you are doing a Hartmann procedure for malignancy or any other region, then
Never go for Hartmann's. Hartmann's is a different procedure. So you should clear in your answer. Hartmann's, it's a different procedure in that we create a left side stoma. It's a colostomy.
yes, sir.
So when we go for a and ileostomy, and most of the time an ileostomy might be a permanent.
Yes, sir. It can be a permanent or temporarily. We can do in FAP, familial adenosis polyposis, or ulcerative colitis. We can do in last resort for lower GI bleeding, where we are doing total proctocolectomy. We can do this in multiple colon cancer when we are doing multiple total proctocolectomy or total colectomy.
So what is the most common complication you come across when you do and ileostomy?
Sir, prolapse is
Apart from prolapse, immediate complications you see in the first or second day. And that's why there is a modification in and ileostomy.
chances of gangrene is more compared to loop ileostomy.
Ischemia is more. Why?
Because the blood supply, the distal most part, the blood supply is hampered because one blood is coming from only one side of mesentery.
So when you bring out the stoma out of the you created a space in the abdominal wall, sometimes it will be compressed at any point of, like it can be compressed at the sheath level, it can be compressed at the skin level. So that's why chances of necrosis more in and ileostomy, and that's why many people are doing and loop ileostomy now to prevent that complications. Okay.
In construction of ileostomy, when you take out the bowel loop, where will you open up the loop?
Sir, after taking 4 to 5 centimeter of the loop, sir, I will take serum. I will usually we open the bowel, sir, and then we take suture
That is
around
what I
it.
am asking. When you open up the bowel, where will you open the bowel? In the center, on
No,
the
sir.
proximal side, on
No,
the distal side?
more toward the distal side, sir.
Why?
The same reason, sir, to make the proximal loop more potting, sir, so larger toward the
So it is that you have to cut more from the proximal side so that the pouting will be easier.
yes.
And it will be more and it will be easier. So not on the distal side, on the proximal side. Number one. Number two, that you said that prolapse. What do you mean by stoma prolapse?
Sir, it can be full thickness or only mucosal prolapse, sir. Mucosal prolapse is more common, sir, and usually managed conservatively. And full thickness prolapse, sir, might require revision surgery, sir.
Just recently, Modi sir said that you just answer what is being asked, right? What I asked, what do you mean by stoma prolapse?
The stoma is coming out of the abdominal wall, sir.
So it is basically what you say or called is a telescoping of a distal part, right? The
Yes.
stoma is coming out through that. So what are the causes? Why it occurs?
Sir, it can occur if we haven't fixed properly the bowel, sir, or it can occur if intra-abdominal pressure is raised, sir.
Even if the intra-abdominal pressure is raised, if it is done properly, it is not going to prolapse. So usually our ileostomy or stomas don't prolapse. But in which condition it will prolapse?
Diarrhea. In diarrheal conditions, sir, it might because of hyperperistalsis, sir.
So usually in that case, mucosal prolapse is more. But if the opening in the abdominal wall is bigger, there are chances of prolapse is more. Number one. Number two, the prolapse occurs because of, can it occur into the colon?
Yes, sir.
Which part of the colon?
Sir. Transverse colon.
Yes, it is a transverse loop colostomy. There are more chances of prolapse because of the long mesentery. So it has a place, it has a length, it can prolapse, right? So if not done properly constructed, there are chances in the ileostomy as well as in the transverse loop colostomy, there are chances, more chances of prolapse, right? Okay.
Can I ask one question regarding prolapse? In transverse colostomy, which loop prolapse, proximal or distal?
I don't know, sir.
I don't know why, but always distal. So the theory of peristalsis does not work. It is almost always distal colostomy loop which prolapse. So keep this in mind. It is not always a peristalsis which causes. It's a rather a wide opening which we usually do in transverse colostomy because of the accommodate the omentum and thickened colon. So the gap is larger which allow the prolapse. And there is a theory that if you do not take sheath, chances of prolapse are there, but I don't know. Anybody wants to. So keep that thing in mind.
So that is the next question. Will you suture the sheath with the bowel in temporary ileostomy or not?
No, ma'am. In permanent, we are doing. Temporarily, usually we are not doing.
What is the advantage?
Yeah, why are we not suturing?
What is the advantage?
Advantage, ma'am, there is less vascularity is better if we are not suturing with the sheath, ma'am, because we are not manipulating more.
No. So if you fix with this sheath, it is not going to compromise the vascularity because the mesentery remains between the two bowel loop. So you are giving wrong answer.
Yes.
Why not fixing with the sheath? It depends on the surgeon.
Yes, and it will be difficult during closure also, sir.
Yes.
Because we are doing
That is the answer.
Yes.
It is like for the permanent stoma, you have to fix it with the sheath, and for the temporary stoma, you should avoid, so that you are going to do closure. It's temporary only. Sir, you are muted. Modi sir.
Sorry, I was going to say that reasons for not taking sheath, as I think Gaurang said that yes, it depends upon the surgeon. Some do take and nothing wrong. It is not going to compromise the vascularity. But it will be more difficult at the time of closure one. Second reason, many times when you do ileostomy, the loop is angry looking, hyperemic and friable. So you may create an injury to the bowel while taking sutures with the sheath. One more point is that taking suture with the sheath will avoid the supposedly parastomal hernia. But when you are doing temporary ileostomy, Parastomal hernia is not that significant because you are going to close it anyway. Whereas in an end ileostomy, the biggest problem is a parastomal hernia. I am saying day in and day out because if the gap is more, properly snugly fitting stoma is not done, there can be a parastomal hernia which will be very difficult to treat because then you have to put a mesh, sugar backer, this, that. There are so many points not going to be discussed, but keep this in mind. That's why in end ileostomy, always sheath sutured. It should be snugly fitting, minimum gap between the bowel and the sheath. Whereas here you can compromise because even if the parastomal hernia develop, you can always tackle it at the time of closure. That's why. And here it is a damage control. Loop ileostomy or a temporary ileostomy is always damage control surgery. So no need to do elaborate procedures. Sometimes you take a suture with sheath and may leak and patient may end up with the severe cellulitis. So these are the points. Datta Roy sir, you are listening.
Right.
Please, anything you would like to ask? You are muted, sir. You are muted. Mute, sir.
What
Yes.
what further care should you take in the post-operative period?
Sir, in post-operative care, I will take care of nutrition and electrolyte imbalance of the patient, sir. Stoma care, peristomal.
What is the type of stoma care that you like to take so that there are no post-operative excoriations around the skin?
Yes, sir. In post-operative period, sir, we use the uh, stoma bag appliances, sir. We use the zinc during the when we apply
This
the stoma bag, sir.
in this patient, what type of stoma care has been done?
Sir, here we only changed only one time, sir, this stoma bag, sir. During that time, I applied the stoma powder and sir,
Sanjeev, what was the question?
what stoma care?
Bag. I think, sir, you asked about bag. Datta Roy, sir.
No, I asked him what care would you take for this stoma in the post-operative period?
No, but the last question, I think, type of bag.
Yeah, I intended to go into that.
So say the type of bag which is being used.
Sir, sticking type, transparent.
Stick on type. Okay.
Stick-on type, transparent, single bag is used, sir.
Sir.
So, how frequently do you remove the bag?
Sir, stick-on type usually within a week, sir, 4 to 7 days, between 4 to 7.
Will it stay for 7 days? Stick-on type. So which type of stick-on you are using? Which stays for 7 days?
Sir, sometimes it...
No. Which type you are using?
Stick-on type, sir.
Obviously stick-on. But you know the types of stick-on which comes? Is it with wafer or without wafer?
1 piece, 2 piece.
1 piece, 2 piece.
1 piece.
With wafer, without wafer. Usually 1 piece doesn't come with wafer.
Yes.
So how much time does it? I don't think it will sticking for more than 24 hours. You understand? So why it gives release easily and with wafer it stays for 4 to 5 days. 7 days is very rare. Unless it is after a very long time permanent stomy where the patient is used to and how to apply, then only. But in such an early case, will it stay for 7 days? Unless if ileostomy doesn't move. That is a question I was going to ask. Anyway, I have given answer. So what is the content in wafer normally?
Karaya gum, sir.
Karaya gum and similar adhesives. We keep the right in position. Then usually it is 2 piece. Here it was used only 1 piece. That brings us to a question: has it moved? This ileostomy has moved.
Didn't understand.
So was there output from ileostomy?
Functioning. He's
yes,
talking
sir.
about the
Functioning, yes,
functioning.
sir.
It become functional on post-operative day too, sir. Now on post-operative day 7, it is semi-solid type.
Okay, you have done a loop ileostomy, and after good peristalsis, it is not becoming functioning. So what will you suspect and do?
Sir, I will do peristomal examination whether there is, because of edema, there is a narrowing of the
Peristomal, what is that?
First,
peristomal examination
Perstomal,
yes,
perstomal.
because of edema, it might be narrowing of the lumen, sir.
Mhm.
Second thing, I can think about the paralytic ileus, sir.
I have said good peristalsis. That is what I am repeatedly trying to say. Understand the question and answer. I have
Primary
said good
pathology.
peristalsis.
Primary pathology might be there, sir. Proximal, any perforation, proximal, any obstruction we can miss, sir.
Very good. One thing is right. So usually in such cases, proximal pathology missed, too tight suturing, particularly when the sheath is taken. So there can be and stomal edema. These are the common causes for that. Apart from paralytic is a different thing. Then yes, there will not be a right. So what will you do? You have done a stomal examination, and there is a narrowing at the site of sheath. What will you do? One more point, sorry, twisting. Twisting comes here only. That unfortunately, stomy is brought out twisted, so it will not move easily, which has happened many times, particularly in pediatric patients.
Sir, I will, if any narrowing is there, I will go for refreshing of stoma.
Very good. First thing you can do is remove the sutures and see. If the sheath sutures are taken, you can do it. Second thing you can do is release the sheath. And until it does not work, then the question of refashioning comes. You have done a ileostomy. On a fourth day, you find it is blackened. What will you do?
I will do the tube test, sir.
What is that?
I will that in that, sir. I will place one tube and will see the mucosa of the stoma, sir. If it is blackening present or not. Mostly.
I don't understand what he is saying. I don't understand. What is tube test?
Yes, sir. One tube. I will
Which
pass
tube?
one
Which tube?
glass test tube, sir.
Glass test tube. That is not a tube. Glass test tube. What will you do with it?
In this, sir, under the proper light, I will see the mucosa of the stoma, sir, whether it is blackening present till
I am
the.
saying your stoma is blackened. Don't believe me.
Yes.
Now what will you do?
I will look whether this blackening is present till the sheath or not, sir.
Till the
Sheath, sir, upon you.
feet.
Sir, rectus sheath, sir. If it is present.
Sheath. Oh.
Sheath.
Okay.
If
Sheath ne એને શું લેવા દેવા? Whether
sir,
it is only mucosal blackening or all layer blackening.
yes.
Right? So suppose it is only 2 centimeters, then what will you do?
Expected management. I will go for expected management, sir.
Achha. God will help me.
Sir,
That's what you want to say. In other words, conservative, right?
Yes.
Wait and watch. Why?
Because, sir, stoma will function after a few days. We can wait, sir, for that. Otherwise, if it is not functioning, then only we will go for refreshing, sir.
So one of the reason for non-function is twisting and gangrene should be kept in mind. Yes, when it is a less than 2 centimeter and you can see the line of demarcation on the stoma, you can do wait and watch because the granulation may develop and patient have a functioning stoma. But if it is all layer more than 2-3 centimeter going up to sheath, it will retract and will cause the problem. So in those cases, refashioning or plan B should be done. That brings to, sorry, but Suppose you have done a loop ileostomy like this without passing a rod. On a second day, you see that it has gone inside. What will you do? In other words, what will you do if there is a retracted stoma?
Sir, I will go for refreshing, sir. If it is retracted on post-operative day 2, again we need to go for refreshing.
Yes, it is like that, but there is no peritonitis, abdomen is soft, and the stool is coming out from the hole itself. So what will you do then?
I will take suture from the mucosa locally.
So the best thing to say is examination under anesthesia. Take a patient in OT and reassess whether patient needs refashioning or resuturing. This is the thing you should do. Please, Dattaroy sir.
Garang bhai,
So why retraction? Why we put a spigot when we construct a loop ileostomy? When we do an ileostomy, we not put anything like that. Why we put spigot when we construct loop stoma?
Sir, to prevent the retraction, sir. Early retraction.
Why retraction is there when there is a loop stoma?
Sir,
we are fixing with the scheme. Okay, still we put spigot to prevent retraction. Why?
Sir, because the normal tendency of the bowel will go inside, sir, because we are stretching it outside. So the mesentery will pull inside, sir. If a suture illusion, if anyhow surgical technique is failure or suture material is not good, sir, then it might get reduced. It retracts, sir.
Because it is a pathological bowel which you have brought out. That is the answer. So chances of cut through of stitches is more likely giving rise to retraction of the mesentery. Or if it is a short mesentery and you have pulled out, then it will also help end up with a retraction of the bowel, right?
Yes, sir.
Okay.
I think we can go on to the next case, or
yeah.
the closure of ileostomy.
When will you close?
Ma'am, in this patient after intensive phase, ma'am, I will close.
What do you mean by intensive phase?
Ma'am,
Don't give answers like that in the examination. Be particular about what you are answering. So unnecessary, you'll get more questions if you answer like that. You have to be straight away up to the point. When would you like to close this ileostomy?
after 6 to 8 weeks.
6 weeks. Routinely we do after 6 weeks. So you say 6 weeks. Then let the examiner to ask all the patients. Then you say it's if what you answered previously. Like, right? Like that.
What care you should taken care before you planning for closure in patients? What are the points you would take care before you planning for closure?
Yes, sir. I will look for the distal patency, whether primary cause of the stoma is resolved or not, and anal tone, and whether it is loop ileostomy or in ileostomy with mucus fistula is there or not. So that in that case we need to go for laparotomy. We will plan like that. and also the nutritional status of the patient at the time of closure, any local site complication or intra-abdominal any complication is there or not.
How do you do the closure? Are there different methods of closing the ileostomy, or there's only one method of closing the ileostomy?
Yes, sir. Different methods are there, sir. Intraperitoneal.
Which one would you prefer?
In intraperitoneal local site closure, sir. Not by lapro.
It's now always intraperitoneal. Anything specific about the closure?
Sir, in this patient, I will close the anterior wall of the intestine, sir, by mucosa inverting suture.
Any other method?
The resection and anastomosis, sir.
So when would you do a resection anastomosis? When you would like to resect the ileostomy, the stoma part?
Sir.
Sometimes you have to do it. When?
Yes, sir. If we are suspecting stenosis after the stoma closure, sir, the lumen, if lumen get narrowing after the stoma closure, sir, or vascularity is hampered or bowel condition is not very good, sir.
અપૂર્વભાઈ બીજું કેસ લઈએ?
હા સાહેબ, મને બી એવું જ લાગે છે. I think we have covered almost everything.
What is divergent colitis?
Sir, divergent colitis is disused atrophy of the distal bowel, sir.
Colon.
Distal colon, sir.
So how will you prevent it?
Sir, distal was by giving distal was.
How will it help?
Sir, it will help by preserving the normal intestinal flora, sir.
Anything else? It will preserve the absorption capacity of the colon when you give daily wash. Will you give wash with which material? Or
Sir,
which solution you will use?
Sir, usually tap water or drinking water.
What will happen you use tap water or drinking water?
Sir, that is we are giving directly into the lumen, so it will not cause any infection or
infection. I am not worried about infection.
It will preserve the peristalsis and absorption.
No, what problem will it cause? Shall preserve peristalsis? Fine.
Distally, the fecal, whatever fecal material is going from proximal to distal, it will also get clear.
Have you heard the word water intoxication?
Intoxication?
Water intoxication. So even when the patient goes home and you advise the patient to take a wash, you always advise him or her to put a salt along with the water. Why?
Sir, chances of hyponatremia.
Hyponatremia, yes.
No, it is isotonic saline.
Which is
so
usually used.
That is tolerated very well by the patient, and all the fluid will not get absorbed. So mucosa will not become edematous. So a simple water is not advised. It should be mixed with little bit pinch of salt, right?
Yes.
Isotonic solution.
Yes.
What is isotonic solution?
What time earliest you can close this ileostomy? Earliest time when you can close?
2 weeks.
2 weeks. Why 2 weeks? Any reason? Okay, guesswork.
Sanjeev? You must have thought of something, Sanjeev. Before the answer.
You are exam going 3rd year. You must have seen number of ileostomy. Did anybody, madam, I am very sure will not close after 2 weeks. So why did you say 2 weeks? And why there is time limit? Most of time depends upon the disease, which we usually give minimum 3 weeks, 21 day stage of inflammation. When you operate any patient, it will cause local inflammation. And starting of the scarring is the time when earliest you can close, the sutures will hold. Usually preferred is 1.5 months when ileostomy becomes stabilized. Ideally speaking, why you should not wait too long if you can close. Again, the reason is formation of strong fibrosis, which will prevent the closure and make it more difficult. Right? Second, divergent colitis is a possibility which will be there. If it is a ileostomy, again the skin problem will be more as the time goes. And again, it will hinder the closure. So not too early, not too late. That is the usual rule in a loop ileostomy when you close it. Right? These sutures, when will you remove these sutures? Or will you keep it? Now, these are the questions will be asked. So anticipate those questions, though they may not be important.
Usually we are not removing these sutures.
Why? You are right. Many surgeons do not remove. After 10 days, you can remove. Why these sutures are taken? What is that procedure known as?
Primary maturation.
Maturation. So what is maturation?
Maturation is
અપૂર્વ ભાઈ ચાલુ રાખું છું. Sorry, but I wanted to
No,
ask.
that is fine, sir. After the short cases, it is for their benefit, sir.
Yes, exactly. Because those are the random questions, those are going to be asked. So you know what is maturation is epithelialization between skin and mucosa. That is a maturation. So they become one. Normally they are not one. So initially you have to take sutures. So after 7 to 10 days, when the maturation is achieved, you can remove sutures. So what is primary maturation?
Primary maturation, what we are doing during the surgery, sir, by taking the stitches between the skin and mucosa.
What is secondary maturation?
Secondary maturation is the gradual epithelialization between the skin and
How
mucosa.
do you do it gradually? Huh?
During the
Cannot do it
course
gradually.
Secondary maturation being done.
Exactly. That's what is sir.
That was
We
done.
don't do it now.
That was done in the olden days.
Yes.
They used to bring out the loop, just open up, fix it to the sheath, and rest they would just open it up, allow it to heal by granulation. So they wouldn't take primary sutures between the skin, most of the time between the skin and the wall of the bowel.
So in a stomy, always primary maturation. I am talking of past, but you can do a secondary maturation when the viability is doubtful, where the ileum itself is not there. And second, one more point, when you can achieve secondary maturation, when obstruction done for obstruction and obstruction is not very acute. In colon particularly, it was done. Nowadays, even there was a tertiary maturation. That's right. There is a one last question I will ask you. We were talking about double barrel stone. What is that? I did not understand what you say. What is double barrel ileostome? Apurva, this is the last question I'm asking.
If the proximal and distal bowel is taken through the same defect in the abdominal walls.
And when they are taken from separate defect?
This is in ileostomy with mucus fistula.
Mucus fistula. So what is double barrel is the two loop, though their edges are not attached.
Yes.
They are not, though they are two, they are not attached. Usually it is done when you have done a resection with stone and you do not suture the posterior layer. Considering that it will help to prevent the content overflowing into distal. So if you really want to have a complete divergent stomy, it is better to go for a separate opening, maybe nearby to each other. The disadvantage is, what will be the disadvantage of stomy with mucus fistula?
Sir, laparotomy.
Yes, you need a formal laparotomy for a closure like a Hartmann. You need a formal. I think, Apurva, that is more than sufficient. Thank you.
Thank you, sir. So we'll proceed with the another case, case of amputation stump. Sanjeev, who is presenting?
Sir, Gaurav.
Sanjeev, you did well. Congratulations.
Thank you, sir. Thank you, ma'am.
Good morning, sir.
Please start sharing. नहीं screen share कर दो. We are seeing
Yes.
your face.
Yes. Good morning, sir. I'm Dr. Gaurav Patel, a third-year resident, presenting a case on right abdominal amputation stumps. A 49-year-old female residing at Daud, farmer by occupation, with elective right-sided abdominal amputation with debridement over left foot 7 days ago. Patient is having complaint of pain at stump site and discharge and blackening since last 2 days. No history of fever, swelling, gapping, or restriction of movement at presence. Drain was removed on 4th post-operative day. Patient had a history of pain over right lower limb after fall approximately 25 days ago, following which she developed loss of sensation and movement over 2 days and discoloration of right foot that gradually progressed and reached up to below knee over 3 days. Patient was managed conservatively for 10 days at Dahod Government Hospital, and then patient came to Civil Hospital Ahmedabad approximately 9 days ago. And patient developed foul-smelling discharge, after which she went under the surgeries. Patient had a history of something bite over left foot approximately 1 month ago, where she developed blackening, which was managed conservatively at Dahod Government Hospital and underwent debridement along with right-sided abdominal amputation. No history of fever, pain while walking, pain at rest, abdominal pain, chest pain, headache, blackout, blurring of vision, polyuria, polydipsia, and polyphagia. Patient is a newly diagnosed case of diabetes mellitus and hypertension for last 20 days. No history of addiction. Patient is para 4, abortion 0, and live birth 4, and menopause since last 2 years. On examination, inspection, I have examined the patient under proper exposure with adequate light after informed consent in presence of female attendants. Right lower limb, a bony amputation stump of approximately 25 centimeter length with a stitch line of approximately 20 centimeter with blackish discoloration over medial third of stump. Minimal serosanguinous soakage is present. Surrounding skin appears healthy. Approximately 1 into 0.5 centimeter drain site over lateral aspect over lower flap with minimal serous soakage. Hip joint movements are normals. On left lower limb, there is an ulcer of size approximately 4 into 3 centimeter, irregular in shape.
We should skip this part. We are talking only of amputation.
Yes.
So forget this too.
Yes.
We'll take it as a past history or something, right?
Yes.
So, fine.
Yes. On palpation, right lower limb, no rise of temperature or tenderness surrounding stitch line. Length of stump from greater trochanter is 24 centimeter with all inspectory findings are confirmed. With a smooth contour without any palpable bony spur. Minimal serosanguinous discharge is present over medial aspect of stitch line. No palpable inguinal lymphadenopathy is present. On left lower limb, there is cold limb up to lower one third of leg. Yes.
Only the amputation stump, please.
Yes. On pulsation, right lower limb femoral artery is present. Rest are not accessible due to amputations. And in left lower limb, femoral artery is present. Rest pulsations are absent. Sir. Pulsation of both upper limbs are normals. Right-sided abdominal amputation stump operated for wet gangrene due to acute limb ischemia due to trauma in a patient of bilateral chronic arterial insufficiency due to atherosclerosis with ulcer over left foot in a newly diagnosed case of diabetes mellitus and hypertension.
Datta sir?
Yeah.
Go to the first slide.
Yes, sir.
Let's just go to the first slide, yeah.
Gaurav will take it only as a case of amputation. We'll forget the limb except for the pulsation part. Right?
Yes, sir.
Why did you come to the conclusion that this was the indication was in for a case of wet gangrene?
Because patient had a foul smelling discharge also present, sir.
How far was the blackening?
Since last 25 days, sir.
What was the extent of the gangrene?
Up to below knees.
Blackening.
Up to below knees.
So what is the type of amputation done here?
Above knee amputation, sir.
What are the different types of amputations that you know?
In a lower limb, sir, digital amputation, raise amputation, sir, Gillis amputation, transmetatarsal, tarsometatarsal Lisfranc amputation, mid-tarsal Chopard's amputation, Sims amputation, Pirogov's amputation, below knee Burgess amputation, knee disarticulation, transcondylar Grittis-Stokes amputation, above knee amputation, hip disarticulation, and hemipelvectomies.
This was a case of moist gangrene or wet gangrene that you're talking about, right?
Yes, sir.
So, and looking to the present blackening of the margins, could anything different have been done in this patient?
Any other possibilities you could have done something better for this patient? Sir is asking that.
During surgery, we could have
any different type of amputation you could have done.
We could have done a guillotine amputation, but due to below knee, we didn't.
So what do you understand by a guillotine amputation, and what are the indications?
Guillotine amputation done in a septic patients in a gangrene due to gangrene. We cut the skin, muscles, and bone at the same level to complete the procedure earlier.
What is a guillotine?
Guillotine is it was used in a earlier period for decapitate the patient, decapitate the to prisoner or to someone punishment.
In which country?
France, sir.
France, French Revolution.
Yes.
Okay. So
what is the nowadays most commonest indication for doing the guillotine amputation?
Gas gangrene, ma'am, in patients
One
of
is
gas.
an excavating person from trapped in the accident. That is the main commonest amputation there. Right?
Yes.
Okay.
So rather than guillotine, in such cases, what you can do is that you can keep it open.
Yes.
Amputation is above knee, and flaps are created because see, guillotine is something where you want to complete it fast.
Yes, sir.
So if the patient is good enough for a couple of more minutes, you can always create a healthy this thing, so that chance of tension and chance of infection are less.
Yes.
You do the routine procedure of above knee amputation, but don't close the tissues.
Yes, sir.
You can use WAC.
Sorry.
You can use WAC. What is WAC? Gaurang,
it is
WAC, VSE WAC.
Okay. It is a negative pressure wound therapy for absorbing the discharge and a proper better healing of for more healing of granulations.
This is a good amputation stump, bad amputation stump.
It is a good amputation stump, except part of a blackening. Some blackening is present.
No, there is nothing like except. See, once it is except, it cannot be good. You have to understand that.
Yes.
Once it is blackening, it cannot be good, right?
Yes.
So good should have. Okay, in that case, what would be a good amputation stump?
It should have a normal skin It's no complications. No bony spur should be palpable. Adequate muscle padding should be there. Proximal joint movement should be normal. Skin should be freely mobile. If possible, stitch line should be posterior or anterior enough, so it will not it will not be difficult in prosthesis.
And
But
the
in
length. And the
Sorry?
length. Very important.
So
The length.
adequate length of amputation stump should be.
So Gaurav, it starts from the length,
Yes.
adequate length. So you have to speak about the adequate length for the above knee amputation. So what is the adequate length for above knee amputation?
Approximately 25 centimeter from a greater trochanter, ma'am.
How will you assess greater trochanter?
I will ask the patient to I will ask the patient to be in a lateral position, and then I will, from the ischial tuberosity, I will go downward. The most prominent part will be greater trochanter. From
So
the
you have to
iliac
measure
crest.
before you start draw the line for cutting the skin, right?
Yes,
That
ma'am.
is most important thing. Okay.
Where would you place the suture line? Anteriorly or posteriorly in a good amputation stump, to develop a good amputation stump?
Posteriorly.
Why posteriorly? Why not anteriorly? Main bulk of muscle comes from posteriorly. So the padding would be more at the stump level where you will place a prosthesis. It would be more if we get the bulk from posterior.
Yes.
So,
but
yes, sir.
in above knee amputation, which type of flap is this? Here the
What?
suture lines is the median, in between, not anteriorly, not posteriorly. It is in the midline. Moreover,
Yeah.
so it is a skew flap.
Yes.
What would be the complications after post immediate period? We have got some blackening out there. What would you be doing for that?
It can be if a patient is having a blackening, I can do conservative management, as well as if there is a collection or more discharge is present, I can
This is the
remove the.
patient. This is your patient. The
Yes.
patient has developed blackening at one aspect of the margins. Now, what do you plan to do?
Currently, I will go for a conservative management, but if discharge is more, then I will go for a removal of 1 or 2 stitches from the lateral aspect of the joint, or most from the site where the discharge.
Any discharge at the moment?
Yes, sir. Serosanguinous discharge is present, but it is mild or minimal discharges there is.
Once there is blackening and there is discharge, the principle is allow the discharge to have a free drainage. So don't wait. Otherwise, there'll be collection inside, and it will involve the whole of the suture line.
Yes, sir.
And more importantly, as far as the vascularity is concerned, you should be very careful. I mean, there are incidences, or you can always go for an angioplasty or something before you go plan an amputation, so
Yes.
that you can salvage the stump. See, basically, because on the opposite side also you said above popliteal everything is absent.
Yes,
Sorry,
sir.
below popliteal, even popliteal is absent.
Yes, sir.
So you need to be careful. Or even in the primary initial phase itself, immediately after amputation, you continue with the antiplatelet and everything, so that you are supposed to anticipate such a issue,
Yes, sir.
especially when vascularity is not there.
So, like, tell me any investigation done to see the vascularity in these patients?
We can go for
Say for
a.
Again, there is nothing like can, beta.
Yes, sir.
This is your patient and what you will do. In
Or
exam, never give a
I'll just modify the question. What are the investigations that can be done to assess the vascularity of a limb before going in for amputation?
First is a duplex cancer. Second is a CT angiography, sir. We can go for a CT. I can go for a CT. I will go for a CT angiography, sir. Then
So every patients of lower limb ischemia, you go for a CT angiography. What are the indications? Not in every patient we go for a CT angio. Which when you go for a CT angio?
if I am planning for any revascularization procedure, then
Yeah.
I will go for a CT angiography. Sir.
Yeah.
And we
And
can
the
assess
thing,
the
so this patient having a right side abony amputation, left side already no pulses palpable below the knee. Okay.
yes.
So what are the investigation done in this patient regarding vascularity in this patient? It is done any reports like Doppler has been done or angiography?
Yes, sir. CT angiography has been done, sir.
So what is the status of CT angiography in this patient?
So
right
was
side,
it done post-operatively or a pre-operatively?
it was done, sir, pre-operatively.
Pre-operative. Sir is asking now the blackening has occurred. Anyway, tell that what was the finding of CT angio?
In right side, there was a complete blockage at the level of femoral vessel, sir. And in the left side, there is a complete blockage at femoral level as well as popliteal level. But there is a vascularity up to the lower 1/3 of leg due to collaterals. Distal runoff is present.
So, any other investigation?
It may not be happening in your institute, but what are the different investigations that are available?
Ankle brachial pressure index, I can do for this. And
would you place it as a traumatic this loss, or it is because of some generalized disease? Because what I find by your history, diabetes is very recent.
yes,
and you have said a history of this sudden loss of sensation and rest of the movements. And then you have converted traumatic into I think it was some sort of a mix-up of whether it was my wet gangrene or dry gangrene. What is the difference in outcome in wet and dry gangrene? Because the other limb is also at some level of ischemia.
yes.
So, what is the difference between outcomes in both these types of gangrenes? Does it make any difference?
In dry gangrene, it is due to it is chronic insufficiency, so it can go under the auto amputate, and I can wait for the amputation. So in wet gangrene, due to superimposing infection, I will have to amputate patient earlier. And in a dry gangrene, I can go for revascularization earlier if possible. But in a wet gangrene, if sepsis is present, then I will have to amputate the patient first before revascularization.
Does dry gangrene occur more in diabetes or vascular insufficiencies?
In vascular insufficiency, dry gangrene will be more.
When you expect a diabetic patient to develop this type of what we would say a broader term diabetic foot and its complications, at what duration of diabetes mellitus?
If it is uncontrolled diabetes, if it is
duration, how long the diabetes may be present for chronic complications to occur?
Approximately more than 5 to 10 years. 5 years, sir.
More than 5 to 10 years. 10 years would be a bit enough time. Because what I was thinking, could we have salvaged it as you are planning for the opposite limb? Could we have solved had the patient treated earlier? That was what I was thinking, because of sudden that trauma, and then especially these patients care needs to be taken a bit early, more aggressive. How far we can help, I don't know, but that was just a suggestion, right?
Datta sir, you were asking about some investigation. Please enlighten.
Any transcutaneous investigation that can be done?
Yes, sir. Transcutaneous oxygen saturation, we can measure.
How will it help?
It will help to it will help to differentiate it is a critical limb ischemia or not, sir, to differentiate.
In this patient, in your patient, will it help?
Yes, sir. To see the vascularity of the flap, it will be helpful.
Gaurang, anything you would like, Kirit?
Yes, sir. See, Gaurang,
yes.
In your case, the amputation stump is there and there is some blackening and there is some discharge. So, what do you feel? Why there is a discharge? Is it the infection or is it the vascular compromise?
It is due to vascular compromise. Due to might be undergoing necrosis of the tissue, it can cause the discharge presence.
Since you said it was a wet gangrene.
Yes, sir.
So when you did amputation, at that time any culture sensitive was sent, or was there any frank first discharge?
Foul smelling serious discharge was present, sir, but not the first discharge was not present.
Okay. So what you could have done at the time of surgery to improve the amputation stump viability?
I will go for, sir, embolectomy or thrombectomy by Fogarty's balloon catheter, sir.
Yes, at that time you should have used Fogarty. Did you use it? At the time of surgery, you know it?
Sir, I don't know about the intraoperative findings.
Okay, okay. So you said that in your final diagnosis, you said that it is because of the atherosclerosis.
Yes, sir.
So Apurva sir rightly said that we are not going to discuss about the ulcer over the left foot, but
yes.
Since the pulsation status is downward, you will be asked in your exam about the PVD, peripheral arterial disease, and atherosclerosis.
Yes,
but
sir.
Since female is 49 years of age and only 20 days history of a diabetes and hypertension, how you can say it is because of atherosclerosis? How you justify it?
Because there is a loss of pulsation is also present, sir, and opposite limb is cold up to the lower one third of leg also, sir.
Okay, so that is what sir was asking, that the minimum, how much amount of duration that diabetes mellitus will take for the permanent changes to occur in the arteries.
I have one curiosity.
Yes.
Is it a common to have at the age of 49 years atherosclerosis in female?
No, sir. It is.
So what may be the history? Diabetes must be there, but patient has not
noticed.
Not got investigated. That
Yes.
might be the reason. So diabetic must be since long, which is causing. Now the question is that what will you do to this blackening?
I will open the stitches, sir.
How many stitches? Whole line or partial?
If discharge is coming from any single point, then I will open it. Otherwise, the most medial or lateral aspect, so I can drain the discharge.
How will it help?
It will decrease the tension over the skin or
so
flaps.
what can be the cause of blackening in this patient?
It might be due to tight.
One is increased pressure inside the stump.
Yes.
Right? One, right, which can lead to jeopardizing the flap vascularity. And that's why the subcutaneous, that is important, which will help you whether actually how much vascularity is there. Yes?
Then might due to atherosclerosis is a generalized condition. There can be hampered affected vessels of the femoral or iliac level at the also, sir. That's why.
No. You have an investigation now, right?
Yes.
What does it say?
There is a blockage at the common femoral artery levels.
So will this take Ebony amputation, though the femoral is blocked? In other words, on which vessel Ebony amputation is based? Because that way it has to get supply from somewhere.
On a superficial femoral arteries.
Not profunda.
All both.
Both. So that is a block. You say common femoral is blocked.
Yes.
So how this stump will survive? Because even in exam, you have to palpate the femoral in Ebony amputation. Did you palpate here, I hope?
Yes, sir, I palpated.
So it is not palpable.
It is palpable.
It is palpable.
Yes.
Oh, then then I withdraw my question. Then it is no question. Because investigation you may not be knowing. So with the palpable femoral, why it is blackened? Ideally, if the femoral is palpable, the flap should be good. So what are the common causes for flap necrosis? Enumerate them. One, you have said progression of disease. Second, there can be a lot of tension inside, which causes the vascularity ischemia. What else can be the cause?
Infection.
Infection, yes, agreed. What else? Particularly patient is diabetic. That again the reason you should open up the stump site. It can cause the problem. So yes, infection, particularly in the presence of diabetes. What else? Handling, improper handling of the flap at the time of creating the stump. You should always keep that thing in mind. One is increased requirement due to surgery. The limb might be, or skin might be viable, but as you do perform the amputation, the metabolic requirement, oxygen requirement increases, which cannot be coped. One more reason, due to surgery, there may be injury to some collaterals, which were supplying the skin of this particular flap, which has gone and can cause the black. Okay, so next what will you do? You open the 2-3 stitches, but blackening is increasing.
I will open all the stitches.
You have to open all the stitches. Then what?
If it is still at the, I will go for a revision of a stump.
Okay. What is revision of stump?
If it is done more lower, I will go for more upper amputation. I will remove more.
What is revision of stump? I'm not saying you are mixing the question. You have said I will go for revision. So what is revision of stump?
I will remove necrosed part of the.
That is debridement. It is not a revision of stump.
So it should be done debridement first.
Yes. So first I will try to debride, remove the skin, remove the dead muscle and wait. Then if bone is exposed and muscles are good, you go for a revision. If possible, if the length permits, or you go one proximal. So what will be the ideal length in Ebony amputation, which can be preserved?
Sorry, sir.
What is a normally ideal length of Ebony amputation stump? According to book.
25 centimeter from the greater trochanter.
Tip of greater trochanter. Don't forget the word tip, because greater trochanter itself is 7 centimeter. So from where will you take? It's a tip of greater trochanter, 22 dash. So you are unable to maintain that healthy length, then you will go do what?
For hip disarticulation.
Hip disarticulation. Will it be successful in this case? How will you confirm that? Yes, it should be successful. So which investigation is a mandatory? Again, the Doppler. You understand? Again, the Doppler can be useful, and status of iliac vessel will help you to decide whether there will be so in this case, if femoral is blocked, from where will the blood supply come? Supposedly, you say it is present, then there is no problem. Supposedly, it is absent. From where the blood supply will come? Do you understand my question or no?
Yes, sir. Yes, sir.
Then it is fine. Yes.
Sir.
You don't know. That is what the importance of collateral. So which are the sites, collateral site which supply the Ebony amputation stump? Where will you find the collaterals?
At the level of iliac vessels.
But where? We are talking about. One is, if permitted, between profunda femoris and the gluteal vessel, which supply internal communication between internal iliac and the femoral vessel, which is, so in a gluteal region, good collaterals may cause that. And that is why many times in Ebony amputation, you, if in doubt, keep a posterior flap slightly long. Though normally it is in midline or anterior slightly long, but keep this in mind. Posterior flap is more robust than anterior flap even in this, because the gluteal is supplied posteriorly. Muscle mass is posterior. That's what the sir was asking you when there is a question of that. Which type of amputation stump is this? Type of you know the types of amputation stump?
Yes. End bearing or side bearing stump?
Bearing type of stump. Kaya stump? Stump, sorry. I mean, which type of amputation is done?
So sir is asking long posterior or skew, which type?
A skew type of Ebony amputation with both equal flaps.
Okay, both equal flap. That is the important point, right? So which are the other type of stump you know, or amputation you know?
We can go for, I can go long posterior flap.
Okay, if below knee you go long posterior flap. What else?
Single flap amputation is.
What is that? What is single flap amputation? That is below knee, you want to say?
Yeah, yes.
What else? What is guillotine amputation? That's what I'm asking.
If we cut the skin, muscles, and bone at the same level and keep the stump open, it is a guillotine amputation.
Indication?
For septicemia in gas gangrene, patients of gas gangrene. Sir.
One. Any other reason?
For
પાછળથી કોઈએ કહ્યું કઈ?
નહીં સર.
Yes?
Don't know.
Only one indication? When line of demarcation is not well developed, patient general condition is poor, and vascularity is doubtful, you go for a guillotine amputation. Yes, diabetic foot is a one indication, weight gangrene, gas gangrene are other indication, but keep this thing in mind, right? So what is basically one type of, there are usually three type of amputation which are being carried out. One is a flap method, one is a circular method, and third is a guillotine method. Basically, circular method is usually used in upper limb, flap method is in lower limb, and guillotine anywhere when there is an emergency. So these are the broad classification you should remember. Circular means you cut skin in circle without creating a fish mouth flaps or anterior posterior flap, allow it to retract, cut the muscle till it retract, allow it to retract, cut bone at higher level, stage-wise circular cutting. Flap is what we do in lower limb normally, and guillotine as we have discussed. These are the broad three classification for amputation. So what will you call ideal amputation stump?
Adequate length of the amputation stump. Skin
adequate is not a word for idea. Adequate means I believe 20 is adequate. Apurva believe 15 is adequate. What is adequate? Proper. Right? And it can always in a range. It cannot be one, because in some patient, longer patient, shorter patient, thickness, there are so many factors. But yes, should be the length. Here length mean by length of to skin or up to bone?
Up to skins.
Not sure.
Up to skins.
Always bone. Always bone. Right? Always bone. How will you measure the length of skin? Depends upon that, but it is always bone and above that. So keep that thing in mind. Yes, one is a length, ideal length of, adequate is not a proper word. Ideal, adequate may be variable. Then
Skin should be normal.
Skin should be viable and normal.
Healthy stitch line or no?
Scar.
Healthy scar. Healthy scar.
This is the rare you have taken post-op. Normally it is scar. Yes. What else in scar?
No bony spur should be present.
What about scar? Scar is healthy. How will you know this is healthy scar?
It should be healed by primary intention.
Yes. No puckering, no adhesion to muscle. It should be healed by primary intention, and ideally sipping. It should not be stuck to muscle or bone. It should not be on a weight-bearing area. That is a good, healthy amputation scar. Right. What else for ideal amputation stump?
Adequate. No visible bony spur should be present.
Visible. Why there should be visible bony spur? That is never ideal. Don't discuss. Palpable. Palpable.
Yes.
Don't forget the words, which are very important. I understand what you wanted to say. Why I am taking this up? Examiner will catch you. સાંજ પડી હશે અપૂર્વે coffee નહીં પીવડાયું હોય. You understand? Then the examiner, when did you see visible bony spur? And then everything is ruined. Do you understand? So always I tell to all students, think before you speak. It should be a proper answer, maybe short. You may miss one or two things, but what you speak should be proper. Okay, no palpable bony spur. What else?
Proximal joint movement should be normal.
For that, muscle mass, which is very, very important for ideal amputation. One. Second is the shape of the amputation stump, which is very important. No ulceration. Apart, not only on scar, apart from scar. Where is the common site of ulceration apart from scar? If the stump is not proper, where there is a friction with end of the bone, there can be a formation of repeated ulcer and scar, next second scar. The stump should be conical. There should not be sinus, there should not be a discharge. The muscle should be well covering the bone. That is an idea and depends upon the various site. And
so what will happen if you cut muscle more? Sir has said well covering. If you have covered more, what will happen? Dangling of the muscle. Dangling word is used, right? Okay. Particularly when it is a adhered scar. So this adhered scar may be there up to 6 weeks. After that, scar starts separating from the suture line. So if your patient is within 6 weeks, then you will not be able to say about the scar, right? It may be adhered. Okay.
Yes.
And stump should not have any long-term complications. What are those? Apart, we have discussed bony spur, we have discussed scar, this, what other complication?
Stump pain can be there.
What is stump pain?
Due to neuroma or due to infection of the stump, pain can be pain.
Infection of stump? What is that? What do you mean by infection of stump?
Stump.
No, you have said, that's why I'm again the same thing. You think before you speak. We have already discussed those parts.
In chronic complication, phantom limb can be present.
Phantom limb is always present in immediate, not chronic complication. What do you mean by phantom limb?
patient will feel still the limb is there and pain in the limb which is already amputated.
So that is immediate complication.
Yes.
So patient will fall down considering that patient is already having limb.
That is the immediate complication.
That is immediate.
Right? Phantom pain and a phantom limb, those are immediate post-op complication for 15 days. So what is difference between these two?
The patient is feeling that limb is still present, then it is phantom limb. And if it is patient is feeling pain at the that if same pain which was present before the amputation, then it is phantom pain.
Patient has a persistent pain which was there, which is felt in non-existent limb, which was there. Right. Rest pain kind of pain can be there. Right. What is causalgia? That can be a chronic complication.
Causalgia is due to chronic pain due to affected nerves.
What type of pain it is? Chronic pain, but what type of pain? It is rather than pain, it is something else. It is because of the sympathetic reaction. You can compare with the Fresh syndrome, which occurs post-parotid, like that. Cross innervation, giving rise to severe red, inflamed-looking skin with the continuous burning pain, keeping the patient bedridden. That is a causalgia, usually because of the, like you compare always with the parotid, that you will never forget it. Right? Another important complication.
Ulcer.
Ulcer is not, we have already discussed those. Contracture of proximal joint. What is the reason?
Due to inflammation or due to continuous
He is very fond of inflammation and infection. It has nothing to do with inflammation.
Where does the patient develop contracture? Yeah.
What do you do inflammation?
What do you do when you do an amputation? See, below knee or above knee amputation, what do you do? After you have amputated during the first days, what do you do?
Would you like to keep the amputation stump in a particular position?
Yes, sir. In a below knee amputation, in a extended knee is in extended position. In a above knee amputation is also at a hip joint at the extended position.
So flexors are very powerful, right? You don't allow the limb to flex. Otherwise, he is likely to develop a contracture. Flexor contracture is very common.
Yes.
How will you prevent?
Notorious.
How will you prevent this flexor contraction?
By immobilization of the joint and keeping the joint in extended position, as well as a limb physiotherapy.
How will you keep in extended position in the ward?
By putting sandbag or pines above the at the side of the joint and keeping a bandage between them.
One is that cloth. Second is slab. Slab is always there. You can use it. Okay, the patient comes to you and with contracture of the joint, proximal joint, below knee amputation, knee joint is in a fixed flexion position. What will you do?
If it is possible to correct by physiotherapy, I will try first for physiotherapy.
Okay. Ideally speaking, first straighten the limb under anesthesia and then start a vigorous physiotherapy. If it does not come, what will you do then?
Release of
contracture. That is a surgical release of contracture is another important. Still, it doesn't work then. That is, remember, that's why the joint contracture is dangerous. You may have to go for a refashioning because it is practically impossible to apply the prosthesis along with the contracture, because joint is the most important point for the transmission of the weight. Yes, sir. Anybody would like to ask anything?
Datta Sahib, Kirit bhai.
How do you rehabilitate this patient?
Yes.
By ambulation, by physiotherapy, if prosthesis for the movement of joint, or management of comorbidities as patient is newly diagnosed.
How will you ambulate this patient?
In initial phases up to the stump is permanent, I will go for auxiliary crutches or walkers. With walkers.
From partial weight bearing to complete weight. Crutches will do partial weight bearing, but how will you do for the complete weight bearing?
Remember, Gaurav sir is asking in nutshell, even in exam, which kind of prosthesis can be applied? When can you apply the prosthesis? What are the advantages of prosthesis and disadvantages? That is the actual question. You are saying these crutches and general condition, we understand it. Physiotherapy, everything. But unless patient walks, amputation is useless. So answer the question in that context.
In the present setup, crutches is the most primitive way of rehabilitation. Remember that.
Yes.
Most of our patients would go in for crutches. That is by the way. But what is ideal?
I will use for a suction type prosthesis for the above amputations. And with the prosthesis will help the patient for doing a routine activity for an ambulations.
Sir, you are muted. Pankaj bhai, you are
Sorry. What do you mean by suction prosthesis?
It creates a vacuum around the limb to proper adhesion to the joint.
So in other words, let us be there. What are the types of prostheses useful in above knee amputation?
Most it is mostly endoskeletal type with knee joint and with knee joint in situ.
So basically, one is exo, one is endo. What is that?
If prosthesis is based on the outside form structure, then it is exoskeletal.
Yes.
But if it is also having inner pylon or any structure, then it is called endoskeletal prosthesis.
Very good. Second variety of prosthesis, end bearing, side bearing, because the weight bearing is very important. There is the extension of that. Usually nowadays we use combine. What is that? Forget about Jaipur foot, that is fine. It is a very comparatively primitive, and yes, it is very useful in our setup. They are end suction type, but very lightweight and very useful for our patient who cannot afford the complex mechanism of endoskeleton with pylon with spokes gears. Do you understand? Right? So how do we fix the Jaipur foot in above knee amputation?
We will have to.
Have you seen Jaipur foot?
Yes.
Ideal word is a Jaipur limb, Jaipur foot. Yes. You have seen. So how the patient uses it?
With the thigh corsets.
Double. It's a combination. Because of the stump is good, the end of the prosthesis will go in a stump and partially held by then suction mechanism of that as well as the straps. Like that. Do you understand?
Yes.
So that should be kept in mind. Because remember, the prosthesis on its own is a very, very big topic.
Yes.
You know what is such prosthesis?
Yes.
What is that?
Solid ankle cushion heel prosthesis.
Remember, it is usually part of all prosthesis in today's scenario, whether it is a below knee or above knee. Why? Because it you need in above knee particularly two joints, one at the site of knee and one at the site of ankle. At the site of knee, you can have a mechanical joint which is self-locking. Maybe your patient has to lock or straight without tape. Where at the site of ankle, to avoid the complex mechanism, this such prosthesis works as a partial ankle. When you press it, flexion occurs. When you right, that is why it is a solid ankle cushion heel. So when the cushion is pressed, there is a movement like a ankle joint. So which can be isolated when there is a lower limb below knee. Sometimes you can use it, but most of the time it is a part of complex prosthesis which is being used. The commonly many prostheses are developed at, that's why many are known as a UCBL. What is that? You know what is UCBL prosthesis? That is the University of California Bioengineering Laboratory prosthesis, which has done a lot of work. Itself is that. Apurva, anything else?
I think you have got एक question હતો, what is an ideal ileostomy? તમે જો આન્સર આપી શકો બધા સારું છે.
Basically, it is a question for exam. To be frank, there is nothing like ideal ileostomy. Ideal ileostomy is a basically whatever we want is that exact ideal site, which will be lateral 1/3 of rectus muscle, 2/3 lateral to it. Size should be adequate to accommodate the loop or end ileostomy. It should not be protruding too much. It should not be flush. Minimum 2 centimeter of protrusion is a mandatory in a proximal stomy loop. Flush to skin to the distal loop. It should be rare, healthy with semi-solid discharge and fully matured. This is basically. The second question I think somebody asked. What was that?
Paul Mikulicz. Paul
Mikulicz. Datta Roy sir must be knowing it. The point is that it was again a old. When there was a era when we were very much worried about the stomy, will it work and what will happen when you put it back. So what was done is whole disease portion was cut out. It was removed and double barrel type of stomy was done with one wall of both loop is fused to each other. And later on, instead of closing the stomy, their special Paul Mikulicz instrument was that, which is introduced partly one lip is applied in each stoma and pressure is maintained on the two fused wall. So gradually there will be creation of artificial hole there and which will start the going there and gradually the this part will heal. So that was a preventing you need not do the stoma closure. That double barrel part, you apply that Port Mikulicz instrument, it will cause the pressure necrosis of both loop and creation of a stoma inside the loop, and that distal stoma will gradually close. That was the basic in a very high risk patient. Nobody does it nowadays.
Basically, we had that instrument which was kept in the examination at that point of time.
Exactly.
So
it was like a press two end like this, two
magnet.
Endoscopy magnet. I have not seen.
That is like a magnet. The same principle is applied. Do you understand? So yet it does work in a patient who are high risk and you did not do a closure. There might be some sinus persist for a longer bite, but you need not submit the patient for an extra surgery with its own complication. Same principle was applied. There was a discussion about intraperitoneal and extraperitoneal closure of stomy. Yes. In today, at the Datta Roy sir, there is nothing like extraperitoneal today's scenario. But take my word, I have done extraperitoneal. There is only one indication. Only one indication. A patient who has an anorectal malformation or a newborn infant, and when you close it, you don't want to take a chance of intraperitoneal because if there is a leak intraperitoneally, you are goner. So in those cases, the stoma was closed and kept in a extraperitoneal. So if leak occurs, leak comes out and does not develop peritonitis. That was the principle.
I remember Kukareti sir was fond of doing extraperitoneal stomy.
No, not fond of. But he used to do in certain cases.
Yeah.
That's what I think. Okay. I think that answers it. Okay.
Fine, sir. Okay. Thank you, sir. We'll leave, sir. Thank you, sir.
Thank you.
Okay. Thank you, sir. Thank you.
Thank you.
Thank you, everybody.
Thank you, sir.
Welcome.